Welcome back to Grand Rounds. As I generally do, let me remind you to sign the attendance record at the back of the auditorium, and also please fill out the program evaluation, and please give us any ideas you might have in regards to future topics or future speakers. Today, it's my pleasure to introduce Dr. Marc Shulman. Dr. Shulman is board certified in sports medicine, and he and Dr. Sarah Bancroft comprise the sports medicine department at McFarland Clinic, and also are the team physicians for the Iowa State Athletic Department. Dr. Shulman has kindly accepted our invitation today to update us on concussion, and without further ado, please join me in welcoming Dr. Marc Shulman.
All right. Is that working now? All right. Again, just to rephrase that, I want to try to help you understand how we're going to deal with both sports and non-sports concussions in our patients, and how we can kind of tease these out and get the proper treatments for them. I have no disclosures. Nobody pays me for anything for concussion. I will say that I do work with Iowa State as well as part of the McFarland Sports Medicine Group, and some of this data comes from some unpublished stuff that they've done as well, looking with the Big 12 and the NCAA. We'll start off with really sports-related concussions, because that's typically what we see. And there's not a lot of difference between a sports-related and a non-sports concussion. It's not necessarily a blow to the head. It's a blow that causes the head or the brain to move. This can be on the body. It can be to the shoulder. It can be from a fall where there is no head contact. These are short-lived with rapid onset. Almost immediately, or usually within the first several minutes, patients will complain of symptoms, of headaches, of dizziness, of not feeling right. That fogginess, that's something important. That means that something's not right. Allow them to kind of see what's happening if you're on the sideline with these patients. See what's going on. These are neuropathological changes, and it's a functional disturbance. It's not a structural disturbance. It's how the brain is functioning. There is no structural damage to the brain with this. We're not looking for a bleed. This is not severe enough where we'd worry about a brain bleed, or disruption of brain matter, or shifting intracranially. This is functionally. So that's why imaging, as we'll talk about, doesn't help us with this. It's a wide range of symptoms and signs that we see. Does not have to involve loss of consciousness. It's very important. Loss of consciousness does not happen often with this. We'll talk a little bit more about that. But it's an altered sensation. You don't feel right. It's not the loss of consciousness. And then again, we always want to make sure there's no confounders in this. Do they have underlying psychiatric issues? Are there drugs involved? Is there alcohol or medication involved? Is there another injury that could be explaining part of this? When we talk about non-sports concussion, these are also referred to as mild traumatic brain injury or mild head injuries. You don't always see the word concussion as we look at the non-sports. Typically, when we assess these, first thing that people are going to do is the Glasgow Coma Scale, because it's looking at really an injury or something else, and we're not thinking about this non-sports related concussion. But the numbers are pretty interesting. If you look at this, we see anywhere from 1.6 to 3.8 million concussions a year. About 70% of those are sports related. Others, where are they coming from? They're coming from accidents, and they're coming from combat. There's a big NCAA Department of Defense consortium. It's called the Grand Coalition. Not collusion, but coalition. As we look at these and try to put together where the data can go back and forth to help both those in the military and those in sport. And the military ones obviously are some sport related, but these are also from blast injuries and from motor vehicle and aviation injuries. So as we look at this, it's kind of interesting as it comes across. If you look at the pediatric patients, 18% of children in ages 4 to up, these are not sporty. These are falls in the youngest kids. We start going up, though. As the age goes up, you can see the sports-related ones really go up. And it's not necessarily organized sport. This is sport at home, sport play, running around school, running around with their friends. We get to adults, we're coming back closer down to that just under 70%. The older we get, the less frequent that is as far as concussions. Accidents being number 1, 2, and 3 for this. Accidental falls, motor vehicle accidents, and other accidents at home. As we all know, the ICD-9 is full of accidents. We can code for these. So there's not really a lot of that's been put together to say specific accident, but accidents as a whole is what causes these. What happens? The brain gets moved, and everybody's looking for the way that we can kind of measure how this happens, particularly in sport, to try to avoid it. We've used helmet sensors, mouth guards, headbands, skin sensors, video-based review systems. I can tell you right now, none of these can diagnose a concussion or predict a concussion with any accuracy. There's been a big push to put lights on helmets, and that went out for about 4 years ago. Big thing, there was a little light sensor that came on if the helmet got hit too hard. No correlation with the onset of concussion. There are mouth guards. There are mouth guards with sensors in that can transmit how hard you bit down on the mouth guard. Again, this doesn't help. Headbands, trying to register the motion of the head, does not predict concussion. Those who are involved, especially with youth sports, people will be selling you these all the time. I'm telling you right now, they do not work. Oklahoma did a big thing with accelerometers in the football helmets. Most of their concussions were sub-threshold for what would be considered. I can tell you that right now that one of the worst concussions I dealt with were 2 swimmers at Iowa State who collided in the pool while swimming. A very low force injury, but a very significant concussion that lasted for weeks in one of them. We're beginning to think now that it's more the unanticipated blow, which may be low level, but then the head moves a lot in those. So we don't pick those up on sensors. So look at the injury, but anything that's unanticipated, anything that causes it to move. Fall, second fall. We see this often as somebody will fall, slip on the ice, or get hit by somebody, then hit their head on the ground, or hit their head against the other person. It's the second fall, that unanticipated second part, where this is happening. So there are no sensors. It's really going to be the history. We do use a video-based system at Iowa State to look at injuries on the football field. We have immediate access to it on the sideline. The Pac-12 is also doing this now. They're the first 2 conferences to start this. It can show us what happened, but it doesn't tell us if they have a concussion. It's still a clinical diagnosis. We look at the biomechanics and that. You need to talk to the patient. Don't count on these to say, gee, this made my decision. So how do you assess these? Of course, if you want to use a Glasgow-Coma scale on those accidents, that's absolutely appropriate. Again, we're looking at trauma first. The SCAT-5, which is the standardized concussion assessment test. This is not the 5th iteration. There was a 1, 2, or 3. There was no 4. So you know, this is a 5-word test. Part of the test is 5-word, both immediate and delayed recall. There's also a SCAT-10 and SCAT-15 now you can see out there. We're sure using the 5. It's a bit easier. Nobody gets the 10 right. There's normative data for this, but baseline data is really key to doing a lot of this because everybody is different where their baseline is and where those errors are. The SCAT also has to do with the Maddox questions, the orientation. It has reverse number recall. It has reverse months of the year. If you do the 5, it's a 30-point scale. A variation of within 2 points is still considered normal. Anything more than 2, they should be further evaluated. This is what typically will happen on the sideline. I know that there are a number of the sports groups in Ames right now. The high schools are using this as well as some other things. Ames Minor Hockey is using the SCAT. The Ames Lacrosse actually uses a different test, but this is part of it. Ames Minor Hockey does some other things as well we can talk about. And that other stuff we talk about typically is neurocognitive testing. These are computer-based programs that are available. We do one in our office called the C3 Logics program. There's a couple other out there. There's Impact, there's CogState, there's a few more. They're all very typical in what they do, but they all measure different things in different ways. The C3 that we use also has a balance component to it. There's normative data for all these, so when patients come in, we can use normative data. More importantly, we can baseline with them, so we can see reaction time. Everybody remembers the trails A and B. We can do some processing speed. We can do some visual testing with this. We like the C3 because it does the balance with the use of an iPad. So we actually have objective data from the iPad on how much they sway. There's another program actually out there called Sway, which just does balance. And it's really what this is. They wear a harness and they actually balance. And I know my partner's talked about this in the past with you. So we can actually see where their deficits are and work on those as we go through the types of concussion. There's another test that's out there that's being used, somewhat called the Buffalo Concussion Treadmill Test from the University of Buffalo. Basically, they see what happens to you with low-level exercise on a treadmill as you go forward and mark the symptoms as they go forward with this. They say that they can kind of get an idea, delayed, if it's more cognitive, it's more you're feeling. And we'll talk about this because there are different types of concussion. We start teasing these out. We don't use the old scales that I grew up with in medical school, which was the Cantor Scale or the American Academy of Neurology scale. It would look at us and say, okay, if you have no loss of consciousness, but retrograde amnesia for 15 minutes or less, and you're feeling fine, that was your grade 1, and then you were out for a week. If it was the second time it happened, you were out for a month. If you had loss of consciousness, you were out for 2 weeks. All those things are gone. Those scales and those tests and those guidelines should not be used further. Bob Cantu came up with the Cantu Scale and said it basically because it was all based on anecdotal evidence from his years, but we don't want to rely on that anymore. We've got much better data to use, and we can kind of tease more out. So please stay away from calling this grade 1, grade 2, grade 3. Documenting if there is loss of consciousness is important. Documenting any amnesia is important, but that's not the piece that's going to dictate their return and how we're going to treat them. That's just part of the history and trying to further delineate these out. So what are the types? There's the cognitive, there's the headache, there's the anxiety or mood disturbances, there's the vestibular, oculomotor, and then they may have some concomitant things going out with those that involve sleep disturbance and or cervical strain, which can add to these. And that's really the way we like to start to divide these up. Vestibular concussions, balance, dizziness, coordination problems, gait problems, lightheaded, nausea, vomiting, things we typically see in people with vestibular problems. This is the area that seems to be affected the most in these people, and maybe a little bit harder coming back. Athletes who tend to do these type of activities, it varies. Some of them get these, this is really their prime one, otherwise it doesn't bother them at all, and nobody's really sure why. I've talked with some people. We've presented this at American College of Sports Medicine. When I talk about athletes who this really would affect, we talk about divers, gymnasts, wrestlers, cheerleaders who tend to go upside down. That's a very learned response. When this affects them and this part them, they have a hard time coming back because it's delayed, and that's the activity they want to get back to. So if you have those type of athletes, be very careful if they have these dizziness things. We really want to go slow with them as they go upside down and get that position back because this can really bother them. Ocular motor. Usually people who complain of vision problems, double vision, blurred vision, eye strain, especially when they're doing their screen time, which we'll talk about in a little bit. Reading, they may have some accommodation issues, which we do look for. Nystagmus, these people sometimes get a little bit of visual flashing lights. Again, this is not an uncommon thing, and it may have to do with some of the cognitive things that will go along with this. We talk about, because they have difficulty reading and tracking, so it takes them longer to process and to read. So we want to work on this again, specifically if they have these type of problems as you're examining them. Also, you can do some saccades testing where you watch them track back and forth in a sequential manner and see if they start to fatigue as you're doing that. I'll typically test them for 20 to 30 seconds, and we can see fatigue as they track back and forth. You'll see that they'll start jumping, they'll start losing concentration on that, or they'll start complaining of their headache worsening as they try to go back and forth in a reading type motion. Anxiety and mood. We see irritability, we see depression with or without anxiety, or anxiety with or without depression, sadness, frustration, particularly if things go on, they become restless. Parents may say that kids have personality changes. Partners may say that they're not acting the same, they don't see things, they get agitated, they get angry, they're frustrated with what they're doing. There may be some underlying issues that go along with this, so we got to kind of tease that out. Many times you'll see people who have been treated for this in the past and this becomes accentuated, or they've gone off treatment. Maybe fairly recently, maybe in the distant past, they've been on anxiolytics, they've been on antidepressants or SSRIs. So this again may accentuate that and make it harder to deal with, so you got to kind of take the piece separately and put it together. Cognitive, this is more on the memory side. Feeling foggy, feeling slow, very common. Sometimes the only symptom and only type of things that they will present with is just not feeling themselves. This is real. And this is probably the biggest thing. Actually, feeling foggy is the number one symptom of a concussion. where people will complain with, that they just feel foggy, they don't feel quite with it. And that as soon as they tell you that on a sideline, or they come home from school, or they come home from work, or they had an accident, that's enough to say, slow down, we need to have this further evaluated. Or take it easy, let's see what happens. Let's go where we're going. Don't put them right back in the situation immediately if they're playing sports or something to get back into this, because this really, again, if I'm feeling slow, I probably am slow. If I can't react, I'm not going to do things the way I expect them to do, and I'm more prone to other injuries as well. Headaches, migraines. Is it a headache from this? Is it a cervicogenic headache, or is it a true migraine or headache with nausea and vomiting, photophobia? This can be treated as well. We'll talk about that. Is it an exacerbation of a pre-existing condition, or again, is this new or a part of their concussion? Again, you got to tease these out as people recover, because it's hard to sometimes say, is this one or the other, or we have an exacerbation? And that's really where it gets complicated. Sleep disturbances are real. They may sleep more, they may sleep less, they may sleep different. They may feel drowsy, they may have insomnia, they both have trouble falling asleep and or sleeping throughout the night. Usually this is short-lived. We do want to address this early, and we'll talk about it, but this can really exacerbate, again, their symptoms, how they're feeling and how they're doing, to try to get them back into activity, which is really what we're looking for. Last, the cervical strain. We know that the head moved, the brain moved. Did the neck move and strain the neck as well? Stiffness, cervicogenic headache, neck pain, shoulder pain, not feeling right. Again, very tight, hurts when they move. That pain in itself will kind of go along. And when we look at these are not unique. These overlap. None of this is going to add up to 100%. So 60% of people will say they have vestibular problems if they have a concussion. 8% of us have them anyway, if you look at the control groups. In oculomotor, 36% in concussion, 3% normal. 15% of the population has headaches anyway. It goes up to 80% if you have a concussion. But what's underlying? And we have to look at both these together and kind of treat them as they move forward. Anxiety problems, 30% of the population, or mood problems. But again, they can be accentuated. It's doubled when you have a concussion. Cognitive problems, sleep disturbances, you can see these don't exist in a vacuum. They overlap. You can have more than one type. You need to treat the pieces, though, and we'll kind of talk about it. So we assess these clinically first and foremost. And if clinically you believe there's a concussion, I almost guarantee you that there is a concussion, or you will treat them as a concussion. So examine the patient. Talk to the patient. Get the history. Do they have any of it? Do they feel foggy? Do they feel out of sorts? Are they not themselves? Are they having problems doing screening stuff? Back them down and see how it goes. The C3 logic we use, that's that computer-based system. It looks at both cognitive. It does look at the vestibular as well. We do an eye motion on there. It's not real sensitive, but it's not bad. But it has the balance, which is a big part of this. So we talk about SyncThink, iSync. There's a new one out there. As of January 2nd, 2019, one of these companies just got their FDA approval to be used for concussion. Where these are really have been found to be useful for, and I'll explain what it is. It's a system where you actually do tracking with your eyes. And if there's a mismatch in how your eyes are moving, it's very sensitive in saying, do I need to get a CT scan or not? Is there something more going on? True diagnosis of concussion is not nearly as good, but they've just got the approval to market for concussion testing. But it's really not telling us much more than that. It's telling us nothing about their mood. It's telling nothing about their balance, because they're doing this all on a mask. But it is a good tool, and it's been used to say, do we need to go do further imaging? Because that's probably where it is. These things are not cheap either. We've tried it at Iowa State. We've had no correlation with our other concussion testing and having the iSync done. We have not sent anybody for a CT scan yet. BrainScope. It's an EEG machine. I know it's been marketed here because I've gotten emails about it. They're marketing in Des Moines. There is no EEG changes that will tell you if you have a concussion. However, it may outline, again, structural changes that say, hey, we need to look further. Imaging may be needed. This company originally marketed for concussion. They were given a cease and desist by the FDA. However, again, as of January 2nd, when the FDA released all their stuff, they are now allowed to use concussion screening on this. on their marketing again. But again, this is something, again, there's not enough data to say that any EEG is going to do anything for you. This is one of those things, again, there may be a use right now. And their study that they got to see, this was done on 232 patients, so it's not a very big study. But again, looking at CT scan, because the imaging is not going to tell us anything unless there's a structural problem. And if there's one big takeaway, I think right now, that's one of them right now. We don't need to image all these unless you think there's a structural problem. Targeted treatment. If you have migraines, headaches, medications, the new guidelines, and these come out, it is okay if you don't think there's a bleed to go ahead and use an NSAID. I still use acetaminophen first and switch over if it's not working. Abortive migraine treatments, especially in those with history of migraine, are still proper. So treat the migraines. Low-level exercise may help with the headache. We no longer are telling anybody to sit in the dark room. No more than 24 to 48 hours of rest is recommended for any of these symptoms now. Low-level activity is the recommendation. Screen time, everybody's going to ask me, we'll talk about that as we move along here. As tolerated. Do not take away their phones, take away the computer. That may actually make things worse. If they can tolerate it, you are not doing anything to lengthen the concussion by using them. AAP just came out with that guideline as well. Anxiety and mood problems. These are a bit trickier because we know some of the medications take longer to work. If it's prolonged, behavioral therapy works. Medication, or meditation, I should say, relaxation techniques. These have been shown to help. I do have a lot of the Iowa State students who have access to it go over and do biofeedback to try to relax and just try to get back to that sense of what normal is, get them calmed down. Psychotherapy, longer acting again. This is the acute concussion is not going to work, but for those with the underlying problem, and I do see patients, and they have patients referred, who do have underlying depression, anxiety, OCD. This does help with them if they get some counseling or get some psychotherapy to get through that other part so that the concussion symptoms seem to lessen as they go along. Medications. Medications are indicated if they are not responding. If they have been on a previous medication, it is proper to put them back on. If they are on one, please be sure they are taking it, because we all know that noncompliance in these patients, especially in the younger patients, is a big issue. And you will see improvement, I think, if you do these. I have a number of patients I've dealt with through the years, and this is a big thing. That's, no, I'm really not taking my SSRI. If it's kind of a nuance that you haven't done before, for quicker acting, I have used the old tricyclics, and there's good data on them, especially if they're having sleep problems. Low-dose amitriptyline in the evening. If they're having more problems with insomnia or with sleepiness and drowsiness, nortriptyline. These tend to work a little bit quicker. We start off on a low dose. Typically, I'll start these 2 to 3 weeks if they're not getting better. And this is their major problem, anxiety, mood, feeling depressed. Some of this may also be because they're not doing their activities. Again, low-level exercise. Start with walking, low-level things to keep them active. Sitting and doing nothing is as frustrating to anybody who's normally active than the injury that got them there in the first place. And if you talk to people who have knee surgery or shoulder surgery, not doing things is probably the thing that's getting them down as much. So allow them to get back doing things as they can tolerate it. I have known that getting into the gym, even if they're just watching practice or shagging balls or being part of it, can really help with this. So try to get people back involved in things. If it's a school issue, getting them back in school, and we'll talk a little bit about that in a minute here. Vestibular. Vestibular exercise, again, as you'll see, exercise shows up on every one of these. Vestibular rehab, balance and rehab. We have physical therapy department, which does a great job with this. We have some who really enjoy doing this, both the hospital and through the clinic. Refer early before it becomes a problem. Then you'll see that some of that mood stuff coming in again because they're not feeling right. Early referral for this, getting them in to start this stuff, can get them back to that return to play quicker, that return to work quicker, that return to their normal lifestyle quicker. So the idea is to really get things moving, get people enjoying what they're doing. So again, referral to PT would be appropriate in this case. Cognitive. If they're on medication for cognitive issues, be sure they are taking it. ADD, ADHD. There's a couple of things. First of all, it's going to change a lot of the things that we're going to see on that computer-based testing. It's going to change how they're doing in the classroom. It's going to change how they're feeling about things. So if there's an issue with that before, make sure they are taking their medication. I don't have the smart pill. I don't have the thing that's going to get you back, but that's what we can do to get people going. Low-level exercise, start with. Also look at their sleep. We know that tired people do not think as well, are not cognitively as aware. So get them on, I really counsel on proper sleep hygiene. Even with teenagers who love to sleep in on the weekends, keep the same sleep-wake schedule, at least while we're recovering from this. It does make a difference. Oculomotor, vision therapy. Have them do tracking. Do not take away their screens unless they can tolerate 0 minutes. If they can tolerate 5 minutes, let them do 5 minutes. Because from 5 minutes, they'll go to 8 minutes. From 8 minutes, they go to 10 minutes, and it moves up. Let them do that. Again, exercise, you can see, has been on every one of these. I'll guarantee you, if you take away their screens, they're going to be depressed. And you're going to have a longer time. AAP actually came out with the same recommendation. Pediatrics came out with the same thing. Screen time is now as tolerated. Do not take it away. This low-level exercise and moving is really the key to doing a lot of sleep hygiene, again, keeping these things going. If they have prolonged problems with this, there are visual exercises that can be done in vision therapy. Accommodations. This is where we all get into, what are we going to do? How are we going to take care of these people? Because day-to-day you don't see a lot necessarily. There's a House file in Iowa, 2442. This was passed initially. The law was in 2011, which mandated schools in the state of Iowa to have accommodations for a return to play. It did not address prior to that. So the kids have to be evaluated by a licensed healthcare professional, which can be almost anybody who has a license in the state of Iowa, physician, nurse, chiropractor, physical therapist, athletic trainer can clear from a concussion. There's a wide variety out there. This new update, which was passed last year and actually takes effect for the upcoming school year starting in 2019, schools must have a return to learn procedure in place. What does that mean? That means that the schools have to accommodate the students as they go. When we talk about accommodations, what does that mean? That means you start off in school, so you can't tolerate all day. You go part-time. You go until you have symptoms, and then you kind of back out of it. When I counsel patients on this, I say, I want you to go at least the first 2 classes of the day. If you need to take a break, fine. Then maybe you go back for another one. If it's taking more than a couple of days, don't miss the same class every day. Start off with 2 classes. Maybe go to your favorites. No gym class, if that's bothering you. And also, because of the noise, no band or choir. We also have them, allow them, if they're having vision problems and headaches, sunlight's bothering or bright lights, wear your sunglasses in school. Wear your sunglasses at work. Wear ear protection if the noises get you. These are all reasonable accommodations to ease back in. Staying hydrated and good nutrition we know is good for everybody. We give them notes to carry water bottles and snacks with them. Leave classes early. We break up the cognitive stuff. We initially tell in schools, our recommendation is no more than 20 minutes of homework per class. And I've probably gone to school at the wrong time because most kids tell me they don't even have that much anymore. We ask that they be given pre-printed notes. They don't have to worry about taking the notes, but just looking at the notes or a PowerPoint that's been given to them and scratching on the side instead of doing the whole thing, they tend to concentrate better and actually do a little bit better. If that's not available, have friends take notes so they can look at them later. So they can actually concentrate on what's being said. Workplace, trying to do the same routine, getting back in. We know that reaction time gets slowed. No driving, especially with our young drivers who are learning. A lot of these are teenagers. Until they have improved reaction time, are back in school full time and doing these, I take away their driving. You'd be amazed how much quicker they get when you say that to them. Have them do what they can do, though. The schools now are mandated to do this because I get complaints all the time. Gee, they made Bobby go to school all day today. Well, no, Bobby's not. It's not an unexcused absence. It's right on the forms, and we have a form if somebody wants to contact our office. We'll be happy to forward our accommodation sheet. But now, from now on, the schools actually have to have their own plan on file starting for next school year, July 1st. So the schools will have this. Where it doesn't come into effect is with employers. How do you do this with an adult? What type of work are they doing? Can they go part-time? Is there alternate work they can do? Is there a place they can go to be quiet? You can work with them. Again, I don't like taking people out and just saying don't do anything, because doing nothing is almost as bad as trying to do too much. I do tell everybody, no matter what the age, 20-minute walk. If you have to put that in the middle of the day at work, that's maybe the break from work they need, is they should take 20 minutes here and there, but don't go sit where it's dark. Go take a walk. Again, we've gone over through this. Overexertion is as bad as underexertion, but no exertion is worse than all this. Low-level activity, low-level cognition, doing things, keeping them active. My high school kids, yes, if your friends are doing something reasonable and you're reasonable, you can hang out with your friends. Yes, you can go to a movie if the lights don't bother you. Yes, you can do things. The dark room, and I know we just played Mike Leach in football in the Alamo Bowl. The dark room that he had at Texas Tech no longer exists. I've talked to their physicians. This is get out and do things. Acetaminophen, NSAIDs for the headaches, abortive therapy for the migraines if they have them. If the headache's prolonged, think about going over the PT. The headache alone should not keep them out of school, but it can keep them out of activities. Same thing with work. If it's something they can do, a low-level headache, or understand it's not bad, it's not worsening, get them going. Nausea, another big symptom we see. Medicate them. Get them feeling better. The first couple of days at least. Understand that the medications all have side effects. Avoid the phenothiazines because they can really mess them up initially. But don't be afraid to treat the nausea initially. That may get them feeling better much quicker. Sleep disturbance. Proper sleep hygiene. I counsel on that visit 1. If needed, melatonin is fine, the low dose, and that may help them get them through at least the initial time. Avoid any of the benzodiazepines that make them sleep. Trazodone has been used in adults. It's really not well studied in children. I tend to try to stay away from it if at all possible. One of my colleagues out in Pittsburgh has actually been using a little bit of chloral hydrate at times, old school. With the younger kids, he tends to get good results just for a couple of nights to try to get them back on their sleep-wake cycle. Dizziness. Rest is usually good. Not laying in bed doing nothing, but doing it's tolerated. If not, again, get them over to the physical therapist for vestibular therapy. Because the longer they're dizzy, the lousier they're going to feel. Vision therapy for the eye stuff. If you're having prolonged cognitive things, make sure everything else you can think of is addressed, and make sure that they're doing the accommodations, not trying to overdo it. Think about if they have any type of learning disability or any other disabilities. Neck pain, again, physical therapy. Anxiety, mood, appropriate pharmacotherapy for these people. Really important to get them going. Make sure they're doing what they should be doing. Otherwise, you may want to have them evaluated to see if you don't do that in your office, to get them to the right person to see if maybe longer term there's some underlying issues. When should you refer? When do we need to see them? We don't need to see every one of them. We're happy to see them all. We do see plenty. But when you should be really worried about something going on? More than 21 days of symptoms. Typically, these should resolve in 3 to 4 weeks. There are some that will resolve in a week. Very few, but they are there. Now they're getting back to full sport activity. If they're getting repeated or multiple concussions, particularly if there's less force involved or the symptoms are getting worse each time, or there's greater problems cognitively. The activities that our kids do and our adults do, some of them are concussion prone. They're going snowboarding over at Boone. That's a great referral source for us. Lacrosse, hockey, 2 sports my kid does regularly. But if things are getting easier for them to do, that's when they should actually be evaluated again. If you're uncertain of what's going on. I know we've seen a few that have been sent over. Is this really concussion, or is there something else going on with this person? We're happy to evaluate them and see what's going on, and maybe, and give you feedback if we think that, yeah, maybe they did have a concussion, or maybe there's something else underlying that is really poking out at us. We're seeing, and the concussion stuff just isn't panning out. Prevention. How do we prevent our patients from having this? I mean, that's what everybody really wants to know, is how do we avoid this? There's been some studies with fish oils. They don't work. There is no medication that will prevent a concussion. Lots of stuff that's marketed, but there's nothing that's been proven. Equipment. Do I need the $500 helmet? Do I need the $400 mouth guard? There is no equipment shown to reduce concussion. There's been a lot that's been marketed. Helmets are designed to avoid skull fracture. They have not been shown to reduce concussion. There's been lots of ways that we think they may be, and there's been some changes made in them, but as of now, there's no helmet that I will tell you that will absolutely reduce your risk of concussion. Rule changes. Yes and no. Rule changes to our sports are very important in preventing concussion. In some cases, they have made it worse, though. Where have we seen rule changes good? Youth hockey changed about 8 years ago. They changed the body checking rule from 12-year-old to 14-year-old. And we have seen a reduction in youth hockey concussions by letting older kids hit. Where have they not helped? Also in hockey, by mandating face protection. There's more blows to the head now than there ever have been. When the head is protected, it becomes, quote-unquote, legal to hit. The biggest part and the biggest sports dilemma that's going on right now is if people look at women's lacrosse. Lacrosse is the fastest growing sport in America. It does have a relatively high concussion rate, more so in men than in women. Men wear helmets, women do not. Women are allowed to wear eye protection, even that was controversial. The rules are very different in the sport. The women are not allowed to have the stick within 3 feet of the head. It's called the halo rule. So they can't really bring the stick up around the head. Every time they have tried to put head protection on, even without changing the rule, the sticks have come up, and they've decided against doing it. I believe this has been debated now for about the last 10 years, whether women should be wearing helmets or not. At virtually any type of protection, even a headband around the head, the sticks have come up. It's just the feeling that the head is now protected so that the rules don't get enforced as hard and more injuries happen. So, if you really want to prevent things, I want to tell you the best thing you can do. If your kids play sport, if you have interest, become an official. Enforce the rules. Don't yell at them from the sidelines. They're doing the best they can. But really, that's where we've seen the biggest changes in rules. In football, with the targeting rules, we've seen some decrease in concussion, but there's still lots of blows to the head that have nothing to do with a hit to the head. We've seen less head and neck injuries, though, and that's that's been the difference. So it's not the equipment, it's how the rules are enforced. The last question we all want to talk about when we talk about concussion is CTE. There's lots of uncertainty. We think we're getting better, but we're not. There was that original JAMA article we always talk about that showed 99% of NFL players have CTE. Believe me, this is statistically about as flawed as you can get in a study. I don't know if anybody here reads 538, which is the sports analytics site on ESPN. Nate Silver, who also does politics and everything else. Breaking down that, and he's done a great write-up on it and on that website, but really if you start looking at who they looked at and where they got their data from and how they broke it down, that number has no value whatsoever. Probably 20 to 30% of NFL players have CTE or will develop CTE, which is still too high a number, but it's not 100%. We don't know the numbers in other sports such as hockey, lacrosse, soccer, boxing. There's just too much uncertainty out there. We're not sure if it's a repeated low-level or if it's one big hit that set everything off. We're trying to avoid both those. There are all sorts of rule changes coming or in process right now, but is it a concern? Yes. Do we know what to do about it yet? No, except to educate and be aware. With that last bit of non-data, I'll take any questions.
Yes. 2 things. Do you talk to athletes participating in contact sports before they participate regarding some of these things? And second question is, do athletes tend to be untruthful? Because you said one of the most important symptoms is the general feeling of not feeling well.
Yes, we've talked to all of our athletes about what they're doing, and it's nice because now we've got actually, through the sports medicine department, we actually do baseline testing on all the Ames High athletes, all the Gilbert High athletes. Iowa State has their own done. We've now partnered with DMAC over in Boone, with Ellsworth. So they're all getting this pre-concussion stuff with their athletic trainers, or if they come see us in their office for the physicals. So we do talk to them about their risk, proper equipment, and what they're doing. So yes, they are getting it. The only youth league so far that we're doing it with exclusively is Ames Minor Hockey, and we've contacted some others and hopefully expanding that so the hockey kids, which is a high concussion sport, all get this type of information beforehand. When they say you're not being truthful, there's a couple things you can do. A, what's the rest of this testing showing us? Because even if they say that they're feeling great, we do a full symptom checklist, and they kind of check that off with the computer. And believe it or not, they're more accurate with the computer than they are if you ask them. So we give them a whole paper checklist. Even if they lie and say 0 and all that, if we can see their reaction time is down or their balance is off with doing some of this testing, or clinically, they don't look right, or their parents says they don't look right, that's good enough for us. Believe it or not, though, we also get the opposite, is where they say they're feeling well, and they're feeling lousy in there, and they want to get out of things too. We see that, or their parents want them to say, "Oh, they're fine. Let them play tomorrow."
How about at the sideline during the game?
Sideline during the game, again, you can usually, if you're there all the time, you have an idea. If not, you rely on their teammates. We'll also do that. We'll also do that scat on the sideline. Our trainers will do that scat. We'll say, "Hey, can you do these things?" And then, so it gives us, if we don't have their baseline, at least we could use some normative data to say, you're down, 2 points from the baseline, and they tell me you're a pretty smart kid, and you got to use your judgment and instinct. There's nothing wrong, especially in 2019, of looking at a kid and saying, "You know what, you're done for today. Let's take a look at you again tomorrow." And we may decide that tomorrow you don't have a concussion, or this is really low level. We're going to get you right back in return to play. You have no symptoms. Another thing I'll say is, if you say that, ask them again in 5 minutes and see if you get the same answer. Give them 10 minutes rest, see what happens.
I just want to specify that we C3 test even people who are not baseline tested. And we have 50th percentile normative cognitive data through that system as well. So those athletes, at least for the most part, we can see what their normative data is based on gender and age. So even if they don't have a baseline, we have at least a starting point. So.
Thank you.